Thank you all. So I always think it's good to really have an understanding behind the processes that we're treating, even if we're not involved in say, stroke every step of the way. But understanding it really gives a lot of meaning and purpose to when we have to deliver care by this recommendation or that recommendation. So just kind of going into an overview of ischemic stroke, and then we'll talk a lot about the transportation and some of the things just to keep in mind. So it's always a good idea to get a sense of, how huge of a problem stroke is and how much of it is actually preventable. So the estimates are there's 800,000 strokes per year. It's the fifth leading cause of death, a high level of mortality in those who are affected by stroke. And for perspective, the leading cause of death is greater than that seen by breast cancer, for example. But one of the bigger factors is that strokes don't always result in death. They result a lot more often in mortality or disability, I should say. So while many people survive stroke, they're left with their lives changed forever and require additional assistance at home, or at the least sometimes they're not able to return to the vocation that they were before, whether that's employment or caring for the family, for example. So what are the risk factors for stroke? Well, there's several. Some of these you can do something about, and some of them you can't. So you can't change your sex or your family history, and you can't change the fact that you may have hypercoagulable states, for example. But there's a lot of things we can do things about. And so these are some of the modifiable risk factors over here, and I think we're all familiar with those. I always tell patients there's sort of a tier of risk factors. Some are a little bit more important than others. And there's the big three, I say, which is high blood pressure, diabetes, and smoking. So if patients are saying, well, gee, I got, diet, and I've got to do exercise, and I've, got to, make sure my cholesterol is down. Well, those factors aren't going to have near the impact that quitting smoking will, or getting those blood sugars down into a manageable range. Same with high blood pressure. Now we'll go into why blood pressure is often elevated in the setting of stroke, but it's over the long term we want to get that blood pressure down. And then atrial fibrillation is a huge risk that often goes undetected in the acute setting, and we're getting a little better at detecting that over time. So what does a stroke look like? So the biggest factor is the timing of it. So it's the presentation. It's the abrupt change. Within a couple minutes, someone is having something from normal to severe, or sometimes fairly subtle changes in their functioning. So this could be, classically, is something that happens on one side of the body. So we're dealing with numbness or weakness on one side. It doesn't have to involve the entire side. Rarely with brainstem strokes you can get fore-extremity weakness or even loss of consciousness, but that's really quite rare. And so we're better off just focusing on the things that are a little more common. So we can have loss of vision in one eye, such as you might see with amaurosis fugax. That's where you get a clot that comes through the carotid and occludes the vasculature to that eye, and so you'll lose vision in the entire eye. Or if it's a brain cause of vision loss, then you'll get a loss of vision on one half of each eye, although patients usually will say it's in one eye. So while oftentimes it appears to them it's one eye, it's usually just the lateral half of the left side of the visual fields in each eye. Visual field deficits is what that refers to. We can have double vision. Dysarthria, which is slurring of the speech, imprecision in your ability to form consonants, for example, as opposed to aphasia, which could be the problem with understanding speech or the problems with finding the right words. And maybe we just can't get words out. Maybe the words are mixed up, or we're replacing some words for other words that we're intending. And then we can get posterior circulation issues, which is vertigo and ataxia. Double vision is involved in that as well. All right, so I know FAST is sort of the acronym that everybody's familiar with, and we're kind of moving towards this one, which is BFAST, which I think makes all the sense in the world. So it's not officially adopted everywhere, but this really encompasses the main symptoms of stroke. With the FAST acronym, we were talking about weakness or asymmetry of the face, weakness in one arm or the other, and alterations in speech, which are certainly very common, especially for anterior circulation stroke. But we can get abrupt vertigo. We can have double vision, for example, or loss of vision. So those are key components of stroke that I think patients are generally less aware of and probably need to be in order to make sure that we accomplish this, which is getting to help as soon as possible. So there are things that mimic stroke, and so this is always one of the biggest issues, especially in the early tPA days. You'd have someone come in with weakness, sometimes complete paralysis, but there'd be something odd about it. You know, maybe they'd have a headache at the same time. Maybe we'd be very young, and the symptoms don't fit with the anatomic distribution. They may be weak on one side, but their speech is fine despite having a complete right hemiparesis, for example. So a lot of these things are things to be aware of, but they don't really represent a contraindication, meaning if I'm like, gee, I'm not sure, this really could be something along the lines of a conversion disorder. If there's at least some significant suspicion that there is a possibility of stroke here, the thought now is to use your judgment to go ahead and proceed with treatment. And the thought behind that is that these patients that have mimics really are at a low risk for any complications of tPA. So they've done studies, and trust me, we've given tPA to complicated migraines and conversion disorders, and typically there's a minimal risk of hemorrhage or the complications with that. But there's certainly a lot of things that can mimic stroke. So these are kind of the main mechanisms, and I would usually categorize this as three possibilities when we talk to patients. And this gets more to what we do to try and investigate the cause after the fact and help prevent stroke from a secondary basis. So we can have an occlusion or thrombosis within the vessel, and that could be a big vessel, anterior cerebral artery, middle cerebral artery, posterior cerebral artery, or the vertebral basilar system. Or we could have a small vessel. Typically, this is going to be seen in your hypertensive diabetic smokers, so we'll see these smaller strokes. But the process occurs within the brain, so we can't go in and clean out a vessel like we would a carotid. We can't do anything about a cardioembolic source. It's typically medical management, except in the acute setting, and then there's tPA, and with the large vessels, we can do thrombectomy. The large artery, this would be typically carotid. Now you can have basilar artery involvement, but we can't do anything mechanically, at least in terms of endarterectomy for that. Again, acutely, thrombectomy is a possibility. And then about a third of patients will have this as the cause, which is cardiac embolism, typically from atrial fibrillation. However, atrial fibrillation may not be there as a previous documented history. It may come intermittently, and we may actually only document AFib, months later. So it's not as easy as it might seem to figure this out. A lot of the surface echoes, even patients who we know have AFib, we know it came from the heart. The surface and the TEE or esophageal echoes can be negative. So this can be a very difficult thing to look at, and we're looking more at monitoring patients for atrial fibrillation for weeks, if not months after the fact. And then sometimes using a high index of suspicion if we see things that look like an embolic pattern on MRI. We realize that the pathology isn't so much the AFib, but it's more the dysfunction of the atrium. And so with that in mind, we can proceed with anticoagulation. All right, so a little anatomy. This kind of puts the whole cerebrovascular system in a nutshell, basically. So coming off the aorta, we have the main carotid arteries and split into the internal carotid on both sides. This comes into play because when we're considering thrombectomy, so that's what we're doing the RACE score for, and we'll hear about that later. We're really considering somebody who has a large artery distribution stroke in the anterior circulation. So that means we've got the carotid or its distribution involved. We're not considering the posterior circulation, even though in some ways that would make sense, but that's just technically difficult as far as the thrombectomy goes. And it's not been shown to be of significant benefit yet. But if we got the carotid, we got the anterior cerebral artery, which goes up toward the middle. We've got the middle cerebral artery or the posterior cerebral artery. And on the next slide, we'll see some of the distributions of these. So typically your MCA is the most commonly involved, the middle cerebral artery, and that area of involvement is in red. So these are probably the most common patients that we'll be considering thrombectomy for. And that would be someone who has a hemispheric syndrome where there's hemiparesis and aphasia, or if it's on the right hemisphere, we'll have hemiparesis and sensory neglect. Those are the patients that we want to be looking for right off the bat so we can apply the appropriate treatment for them. Posterior cerebral artery is over in this area, and then the anterior cerebral artery is there as well. So recognizing the acute stroke symptoms is sometimes the hardest thing, and you'll have, especially if you're a first responder or you have patients call you on the phone, or even in the hospital when we have somebody who develops acute stroke symptoms, they're not all that easy to recognize. And the patients have a hard time describing it. Something just doesn't feel right. They appear confused. The patients who have visual problems often don't realize they have loss of vision in one half, so they have an agnosia, or they don't realize that they're actually having a deficit. So it takes a few pointed questions to figure out if there is a stroke problem going on. But if you go back to those main kind of BFAST symptoms, is one arm really not working the same as the other arm? Is the speech really, more than just confusion, but there's really the language is abnormal, or they're not understanding what I'm telling them? One of the things to keep in mind, though, is that patients are, by and large, alert and aware during a stroke. So where we sometimes mistakenly think of someone who has a syncopal episode or is lethargic, chances are they have a blood pressure issue or delirium or something else going on. Whereas patients with stroke, they're alert, they just can't sometimes understand what's going on. Typical assessment for a stroke is just like anybody else. So we want to assess airway, breathing and circulation, vital signs, labs, EKG. Realize that there's often going to be a coexistent cardiac issue. So it could be an MI, it could be an arrhythmia. That may even be part of the reason why we're having a stroke. Neuroexam and NIHS stroke scale will help us evaluate exactly what's going on and help us communicate to anybody we're communicating to. And then tPA is going to be available or potentially beneficial if we can get that administered within 4.5 hours. So how do we figure out if it's 4.5 hours? Well, again, easier said than done, but we got to identify a time of onset. So the last known well is just really crucial. And you're going to have to rely on the patients and family, and that's going to be imperfect data. But that's the thing that we got to ask questions, and you ask again a few times. Well, this morning they got up and they seemed like they weren't acting right. Okay. Well, were they fine? Well, they were. I talked to them earlier, and they were fine, and it was really after they started breakfast that they weren't acting right. Or did they really wake up with their symptoms? And that's one of the things that we are always having to try and sort out, but it makes a huge difference. With endovascular therapy, this is the intraarterial approach, catheterization approach to remove a clot within a vessel. We have a longer time window, and we'll go into that a little bit more. Other typical things, monitor the blood pressure and blood glucose, and we'll talk about what to do about those if those are abnormal. So just a note about a CT scan. When we get a CT scan for a stroke evaluation, this patient right here has a major hemispheric stroke. in the acute phase within hours after happening. But as you can tell, not really very obvious. And so with strokes, we can see hemorrhage immediately on CT, but with ischemic strokes, we may see nothing. If you're lucky, maybe we can see a few subtle things, and you can look, there's a slight blurring of the margins of the sulci compared to the other side. We have a little loss of definition of this gray-white junction compared to the other side. But that's stuff that you really can't even be relied on. And occasionally we'll actually see the clot in the MCA on one of the sections, but again, typically the CT will look normal. And in fact, if it doesn't look normal in someone here who has an obvious area of infarction, and this follows that MCA territory, and we've definitely got some swelling. As you can see, this ventricle is a little compressed compared to the other side. But this probably happened 24 hours or more before. And so this is the patient you do not want to give tPA to if you actually see something like this on the scan. There's a high risk of bleeding within the area of ischemia, and so that's the big risk with tPA. MRI would be a lot more helpful for sorting out acute strokes, but it's just typically not practical in most settings to be able to get that within the time frame that we could give somebody tPA. It's just going to slow down the process and delay the tPA administration. But this is a diffusion MRI. So diffusion means that we are able to detect acute ischemia within minutes, typically 15, 20 minutes after the actual stroke event has occurred, which is a pretty neat thing. And we can separate that out from kind of chronic areas of stroke or ischemia. So in this particular case, we can see these areas are very easy to identify, and we can not only say that here's the larger stroke, but we can also say that here's the border between the anterior and the middle cerebral arteries, and we probably have what we call a watershed type of infarction that may have actually involved the entire carotid distribution, but it was this area that suffered the greatest area of stroke. If we see areas of stroke on both sides of the hemispheres, we see one over here and one over here, and they're both of the same time frame, then we can be highly suspicious then that this came from the heart. Because if you have one vessel that's involved in a thrombotic stroke, it's just going to stay within that distribution. The only way you can get multiple at the same time is probably because you threw several clots and we hit both sides of the both sides of the brain circulation. And again, that helps us understand what the etiology of the stroke was. And here's kind of the thought behind why tPA is beneficial. So if we give somebody tPA and they've got a big hemispheric syndrome and they immediately or within the hour they get better, probably wasn't the tPA that helped them. So the tPA actually doesn't really provide immediate benefit for the vast majority of the patients, meaning that clot may have been ready to dissolve and we're dealing more with a TIA than we are a stroke. The brain cells that begin to die within minutes after the lack of oxygen that is supplied or that happens after we occlude a blood vessel. And we're left with this core of infarction, and that tissue is probably not really going to come back. It's not going to be functional again. But what we may have is a much larger area called the penumbra, which is viable but hypoperfused, and that's where we're trying to get benefit in. So if we open that blood vessel up, we restore the flow to the entire area, we're still probably left with some degree of chronic injury, but that's a lot easier to recover from a much larger area. And this is sort of probably the next step in imaging with stroke patients. This is a perfusion study, and what we're looking for is what we call the mismatch. And this may come into play as we're trying to extend that tPA window even out to 9 hours. There's some controversy about that at this point in terms of whether that's beneficial. But if we can do a study and actually show that here is the core of the stroke, the infarct, and here's the penumbra, or we have a mismatch in perfusion. The perfusion is impaired in this entire area, but the actual infarction is just left right here. So if we have a significant discrepancy, then we can still probably provide treatment to these patients even after that 4.5-hour window, or at least that would be the theory, and provide them benefit. This isn't routine right now in most centers, but it probably will be in the near future. So as you're dealing with a stroke patient, and let's say we're either transporting them in the field or maybe we had a patient in the hospital that developed acute stroke, there's a couple of key features that we have to be aware of to make sure that we don't actually make the situation worse. And probably the biggest thing that I see is that we're inappropriately treating blood pressures. So we'll see somebody and they've got a blood pressure of 210 over 100, and the first instinct is, geez, that is really high. That's going to be a problem. Let's get that down right away. And if it's a bleed or hypertensive encephalopathy, that makes some sense. But the biggest issue is that if it's an ischemic stroke, this is the brain trying to make up the difference here. It's trying to compensate for the fact that there's a large area of ischemia going on. And so it's a reactive hypertension that we shouldn't really mess with if we can help it. There's a limit, so if we're up in the 230, 240 range, then we should treat that, at least with a short-acting pharmacotherapy agent that will bring that down at least temporarily. But if you drop that blood pressure down too low, then guess what happens to that penumbra that we're trying to preserve? We lose the perfusion in that area. And I can tell you, I've seen that on many occasions where, what was a little bit of a weakness in the hand went to a complete hemiparesis on that side with just a rapid drop in blood pressure. We also want to try and avoid drops in blood pressure that might be due to arrhythmias or whatever may be the cause. So, fluids or occasionally even medications to raise blood pressure. Don't give them anything to drink, even an aspirin or anything like that. We need to keep them NPO until we make sure that their swallow is safe. So if we need to give rectal aspirin, we can do that, and everything else should be given IV. Really high blood sugars can actually confound a stroke or actually cause stroke mimic symptoms, but we can also have issues where the blood sugar will worsen the actual outcome in the long run, so we want to get those down. And then more for hospital evaluation in the early phase of the stroke management. We want to continue platelets, antiplatelet agents, keep them on their statins. Where did the heart, did the heart have a role in causing the stroke, and make sure we treat any confounding issues with hypoxia or anemia or fevers, for example. Okay, so this has kind of been the new development within the last few years, and this has made stroke an exciting field, but also a little more complicated as well. So when we're having to deal with these patients, it's not just tPA anymore. Now we have to consider whether or not these patients will be an endovascular therapy candidate, or basically someone who would benefit from pulling a clot out of that anterior circulation in one of the major anterior circulation vessels. And the initial studies for this were done in 2015, and they've been looking at this for decades, but these were the first that were consistently positive because they had the right patient selection. And all of them demonstrated significant benefit within, at this point, it was in the 6 to 12-hour window, and they've since found benefit all the way up to 24 hours. The key is that we need an imaging study that looks at the vasculature so we can actually confirm that there's an occlusion there. If you do find that patient, you pull that clot out, and these are all patients that are going to have a big deficit. So, we're not going to be looking at doing this unless we have a major anterior vessel occluded. So these are your, hemiparetic aphasic patients that are really going to have a huge deficit going forward. And if we do that and we get the clot out successfully, we'll see actually a 50% reduction in mortality, and a third of the patients will have a highly functional outcome in this modified Rankin scale score, which is 0 to 2, so that's being relatively independent. And not all of these patients receive tPA, so there's reasons why you can't have tPA, but that doesn't mean you can't have a thrombectomy. So when should we consider thrombectomy? First off, we still need to consider tPA, and you do that almost in parallel and independent of each other. So if they're a tPA candidate, that's the one we have to do within 4.5 hours. That's what we need to consider first. However, we can still consider patients outside that tPA window. If someone is now 6 hours into it, or somewhere within that 24-hour window, realizing that we're going to have some time to evaluate and get that in before 24 hours, so that we suggest that maybe that's about 2 hours. And if we have the symptoms of large vessel stroke, which we'll hear about the RACE score or NIHSS scale of more than 10, but again, in your mind, I'm not so worried about scales. Is there a major hemiparesis? Is there a major deficit, a major language deficit? Those are the things we're going to really be looking at. We're not going to risk a procedure for a variety of reasons. If there's a minor deficit, if this patient is maybe they're very severely demented at baseline, you got to look at what we're trying to accomplish, and is this going to be a worthwhile endeavor? So it really takes a lot of clinical judgment at this stage of the game. Again, we have to have a CT negative for hemorrhage, and a CTA typically is the angiography study that's done that looks for occlusion in one of the major vessels. And again, even if they are patients that can't have tPA, maybe they're anticoagulated, maybe they just had a big surgery, we can still do thrombectomy. So it's really a neat option for patients that oftentimes have some very severe deficits. So I won't go into this because this is going to be detailed later, but this is that RACE score, and basically it's just looking for hemiparesis on one side. Do we have language, which would imply left hemispheric dysfunction? Gaze deviation is included because that almost always involves a large cortical stroke. So if the eyes are kind of both looking to one side and they don't want to come back the other way, that means their frontal lobe is involved, and we've got the frontal eye fields, and therefore, again, it's just a sign of a large vessel stroke. And then with the right hemisphere, this is a little harder, but sometimes there's a neglect. They're not aware of the fact that they can't move the left side in this case, and they may not recognize the deficit or not even recognize their own extremities. And again, just to emphasize, acute stroke patients, as much as we may have thrombectomy on the mind for a big stroke, we still got to do go through that tPA evaluation first, because that's still the first priority. And then the thrombectomy, we'll consider that in tandem, but don't forget about tPA. And that means we need to get them somewhere where they can get tPA first. One of the issues that kind of comes up in transportation is, boy, I've got this patient, I'm out in a small town in Nebraska, where do I go next? Do we go straight to a thrombectomy-capable center like Nebraska Medicine, or do we go somewhere where we can get tPA? And again, first priority is tPA. So you got to go where that gets done first, and then we can evaluate and then transfer again if we need to evaluate for the possibility of thrombectomy. And again, you need to have CTA to be able to consider thrombectomy, so at least that can be accomplished. But the majority of patients, even if we're thinking, boy, this could be a thrombectomy candidate, probably the majority of patients, over 70 to 80%, are probably not actually going to be thrombectomy candidates. So keep that in mind, that it's really a fairly small number of patients we're treating when we talk about thrombectomy. Does anybody have any ideas on what percentage of patients are actually being treated with tPA for stroke? So if all comers come in with a stroke, give me an idea. Does anybody have any guesses on what percentage of patients are actually getting tPA? Yeah, it's low, right? It's about 6.5% at the highest. In some places, it's a lot less than that, closer to 3%. So it kind of speaks to the difficulty in getting these patients to a facility where we can treat them soonest. And again, that's probably the biggest area we can still improve on. And part of that's education, though. Patients just don't recognize when they have a stroke sometimes, and they'll think they won't understand it. They're confused. They go say, well, maybe I'll just take a nap and maybe it'll be better when I wake up. And of course, that's not the thing that people should be thinking about. Obviously, if they had crushing chest pain, they wouldn't go take a nap and see how things went. But the stroke can be a more devastating possibility. So on transportation, I think we can cover this fairly quickly. But again, the mindset still should be time is brain. We can't waste any time. You know, we have millions of neurons that are lost every minute. And so again, not only is this important in the initial phase, but still once we're actually, say we're transporting from a facility that has given tPA and now we need to go to a higher level of care, this doesn't change. So we still need to have that acute transfer mindset where we got to do things as fast as possible, whether that's thrombectomy or just achieving a higher level of ICU care in a timely fashion. So during transportation, we want to do vitals and a neuro assessment, which classically involves these major features: orientation, level of consciousness, pupils, face, speech, strength, and sensation. And we want to make sure also that we're ideally completing the assessment with the transferring RN and then doing that again with the RN at the receiving facility. There's just a lot of issues that can be dropped from one transfer to the next, and we just got to make sure we at least hand off the baton in an accurate manner. Blood pressure parameters are confusing. Before tPA, we can treat blood pressures that are greater than 185 over 110, and then after tPA, we want this. If we're ischemic stroke, let it ride. Again, unless you get exceedingly high, let that blood pressure go, and that's actually going to benefit the patient. If it's a little low, lay them flat and do things to optimize their cerebral perfusion. Hemorrhagic stroke, which we're not going to know until we get that CT, we want that blood pressure in that window where it's not too high or too low of 140 to 160 systolic. During transportation, these are the things we should be monitoring for and should catch your attention. And again, stroke causes sudden changes. So if there's a problem, it's going to happen all at once. So we have a sudden severe headache or acute change in blood pressure, or we are alert and then all of a sudden we're hard to arouse. Or we went from able to lift an arm to now we can't lift the arm or the leg. So these are things that would suggest an acute change in status. And then we got to be sure that that's not a hemorrhage. The risk of cerebral hemorrhage is highest during the tPA infusion. And again, if there's any suspicion, stop it and then assess and then figure out what we want to do. And if we can, we're going to get a stat CT. And then just be aware of angioedema after tPA administration. So this is not common, but in a significant amount of patients. So 1% to 2% of patients, and it can be a acute emergency if we get enough throat, lip, tongue edema to occlude the airway, and it happens quickly. So if that's the case, we need to address it. We should examine the tongue before that and keep that in mind, that if you see a significant change, then we want to catch that before it gets out of control. It does tend to happen toward the end of the tPA administration most commonly. And if you observe it, stop the tPA, and then kind of typical anaphylaxis type of approaches with IV Benadryl, ranitidine, and the epinephrine. And then watch the airway. And then same idea, but we could have issues that are complications outside the nervous system. So if we have a sudden drop of blood pressure, things that would suggest systemic bleeding or internal bleeding, then we want to address that as well, so don't forget about those possibilities. All right. Can anybody identify this president who had a stroke during his tenure? Anyone? Nope, not Roosevelt. Yeah, Woodrow Wilson. So they kept this under wraps apparently at the time, and he was on this tour to sell his idea that the U.S. should be part of the League of Nations at the time. And apparently he collapsed, probably due to a cardiac issue. And then a couple days later had a major stroke, probably cardioembolic. And many people say that he was not able to get his agenda pushed through based on the fact that it was a stroke. But of course, there was a lot of hush-hush at the time, and he didn't make public appearances after that. So stroke has its impacts, doesn't it? I think we're running a little late, but any quick questions on any of that? Yes?
A pre-hospital provider in a community that's 35 miles away, are there any precursors to the symptoms, any signs that we could use to ask family or bystanders to try to clarify that onset? You're right.
Right.
That's so difficult and so important, but we try to start identifying what that is.
Yeah, and patients say, well, no, it just started this morning. And then it was like, well, did you actually see them shortly after they got up? You know, when was the last time that you saw them speak, eat normally, walk normally? And while they may say, well, I know it just happened, but they assume it's just when they saw him, they may have seen him sitting in the chair but didn't really pay attention. So when was the last time that you saw, you know, speech, ambulation, and say eating or drinking normally? Or level of alertness for that matter. So it's tough, but I think if you have to really pin them down and say specifically when was that last time.
Early signs, no warning signs as you see in some other cases.
Yeah, I mean typically it's an abrupt change and it just happens. Sometimes there will be a TIA or a smaller area of infarction that expands, but as best you can, just find out when that change was first. Yes.
I have a question. Since our neuro assessments are so important, you know, the Q15 minutes and then the handoff from like ER to ICU or wherever we're going, do you have a preference on the way we all do it? Because sometimes we're comparing apples and oranges or oranges and tangerines in the same group, but not like, should we all be doing the exact same neuro assessment? Because I know mine are a little bit different than some of the other people. Do you guys have do you have a preference? So we can see a subtle change maybe?
Yeah, I mean, it would be nice if it was a little more uniform. Now, I'm not involved in, you know, that part of the process typically, but as long as you're kind of focusing on the main issues, and, you know, I'm not so worried about, you know, whether their sensation has changed, you know, 10% compared to the last time. In fact, the sensation is something I usually ignore. But is there a big, you know, and you may have to just describe it as opposed to just giving some sort of stat or standard assessment of what the weakness is. You know, they will do this, or, you know, here's their weakness score, the NIH score, but here's what they actually could do. So a little extra information, I think, helps. And its language and its motor function and alertness are probably the biggest things. And again, pupil size and all that, and sensation, a lot less helpful because that's going to change and not be less reliable. All right, thank you very much.